and welcome to this edition of Who Gets the China. Today, I'm super excited to have my good friend Sarah McCarthy with me. She is a LCSW, a licensed clinical social worker working in palliative care, and she's an expert on many things related to aging and caring for older parents, not just as a professional, but also as a daughter who has aging parents. So I thought we'd have a great conversation today about some of the things that she's learned through her work and personal life about navigating the challenges of aging parents. So, Sarah, thanks so much for being here.
Thanks for having me.
So, I would love you to explain what palliative care is, because I think most people, including myself, don't really have a great grasp. So, what is palliative care?
So, palliate in Latin means to cloak. And so, when we think about palliative care, it's to provide an extra layer of support to people who are living with sort of a life-limiting illness and it's starting to present more challenges. And it's also for families. And so, it's really to give people the space to talk about what their medical goals for care are, to really outline what quality of life means to them, to identify their values, and to talk about healthcare treatment preferences or if they have any limits on their care. And so a lot of it is to just really give people an opportunity to share with their families what's most important to them for living well. And we know that people do change their mind about some of these things when they have a life-limiting illness. Maybe at the beginning of the illness, they think they would set limits on their care. But then when they get to that, a point in their illness that is really challenging, they may say their quality of life is acceptable. So it's also an ongoing conversation with people.
So, how do you get introduced to somebody and become a palliative caregiver for them? Like, how does that work for you?
So for us, we have to get a referral from another department where
Oh,
I
okay.
work. And so somebody who has cancer, we would get a referral from oncology. Somebody who has lung disease of any kind, we get a referral from pulmonology. And like renal disease, if they're kind of coming towards end stage renal disease, then we have to get a referral. So the only way where I work, we see people is through a referral.
Okay.
People can self-refer, um, but in the community, people can call an organization that offers palliative care and just ask if they can have a palliative care consult. So there are private companies that are providing palliative care to
Okay.
families and patients.
And then is this kind of an ongoing relationship that you would have?
Yes. So that's one thing too about palliative care. So a small part of palliative care is hospice care. So before, when people would Google palliative care, they would think it was hospice. And so we really are trying to educate the community that hospice is a tiny sliver of palliative care. That is really when somebody's in the last 6 months of life. So palliative care can be from the time of someone gets a diagnosis for a life-limiting illness. And then we follow along as much or as little as somebody wants us to follow along with them. So, for example, if somebody has cancer and they maybe are having symptoms related to their cancer or having a hard time adjusting to the cancer diagnosis, we will be involved with them at the beginning of the diagnosis and help with symptom management, and then maybe not see them for a really long time until they're having more symptoms or if they are having a hard time adjusting to the diagnosis. So we like to follow along for it can be years.
And so, talk to me about the family involvement, because I think for me, this is where it starts to get interesting and personal, right? Like, where would the family get involved, or does the family get involved?
Yeah, we often really want to have family involved as long as the person is okay with having their family involved. So it's really up to the person with the diagnosis to decide when they want their family to participate in these conversations. So some people want to meet with us first and kind of get to know us, establish rapport, really outline their healthcare treatment preferences, talk a lot about adjustment to this illness. And then later on, they may include their family. And some people want their family up front. So it's really up to the person living with the illness to decide when they want their family involved.
So, when is the ideal time for, let's say, an adult child to start participating in these conversations? And as the daughter, like, counsel me, what's a good way? What's a helpful way
Mhm.
for me to be involved versus a way where I'm just maybe causing obstacles or making the process more difficult?
Yeah. Well, I mean, a good time to be involved is really when your parents want you to start being more involved. And so, um, what I mean by that is maybe somebody's living with a life-limiting illness, say like heart failure or something, and they're doing fine. When they start having more challenges, but not quite in crisis mode, I think is probably a really good time for kids to get involved. Because when somebody's doing fine, they don't really want to always be talking about their illness. And so, but when the challenges start coming up and they're maybe going back and forth to the hospital or they're on more medications to control their, heart failure, for example, then it's probably a good time to talk about, hey, mom or dad, like, let's talk a little bit about what your values are. What does quality of life mean to you? Where do you draw the line in the sand, essentially, for what is no longer good quality of life? Knowing that when you get to that point that you thought was no longer good quality of life may all of a sudden be good quality of life because
Hmm.
people are so scared to die. Not everybody, but many people. So then they will live in such a way that maybe they never thought they could live that way before. And so they kind of adjust and cope and make accommodations so that they can live longer to be around for whatever is most important for them.
Hmm.
So I would say the best time is really when the challenges start ramping up. Um, when it becomes really complicated is when kids swoop in and try and kind of take over, and a parent feels like they're losing their voice, losing their independence, their autonomy. They feel guilty. They feel like a burden to their family because of the choices that they're making. That's when things can get really complicated. When the goals for medical care don't align with what a kid thinks is best and what the patient thinks is best for themselves.
I mean, I think this gets to the heart of so much that we're dealing with at this phase of our life, right? I mean,
Hmm.
we want to be helpful. I want to help my mom and dad. I want to get involved. But like, for instance, just to take a non-palliative care example, I'm pretty convinced my dad should have his cataract surgery, but his
Hmm.
doctor keeps telling him, no, you're fine, you're fine, you're fine. And I want to call the doctor and say, why are you not giving my dad his cataract surgery? I think he needs it so he can drive longer, so he can have better vision. But I know my dad would not particularly prefer me to just call myself and say
Hmm.
those things. So I'm trying to gently say to my dad, like, can you ask? Can you follow up? But I mean, I feel like people of his generation don't really question doctors' advice
Hmm.
typically. Um, but so I think as the adult child, like you're walking this line a lot, right? When do I get involved and when do I sit back?
Yeah.
So I mean, are there like suggestions or have you seen things, good or bad examples of where it's been done well or where it's been
Hmm.
done horribly?
Yeah, I mean, I think having the conversations it's really hard. I mean, an example we have is that my siblings and I went home to see my parents because we heard my dad is walking down the stairs backwards.
Oh no.
And so we're like, what is going on? And so we go there. We're going to have this whole conversation about can you stay in your home if you're going down the stairs backwards? And it just never, the timing never presented itself. So then we're all sitting at breakfast, and my dad is going down the stairs backwards. And my brother, who's always a comedian in the family, starts, he goes up the stairs and comes down backwards and starts serving breakfast backwards, sitting in his chair, but doing everything backwards. And so that was a good prompt to have the conversation about, okay, like what is going on? And he's going down the stairs backwards, not because he has memory loss, but because his legs hurt and it feels better to go down backwards. But I think having the conversation is really hard, but I think if you allow people the space and tell them it's a gift to your family to
Hmm.
have these conversations around what is most important to you and to let them know, like, this is out of love. Like, we're doing this because we love you and we
Hmm.
want to make sure that you're getting care that you want and you're not getting care that you don't want. So for the example of the cataract surgery, it was sort of like, hey, Dad, like it sounds like you don't want to have cataract surgery. Let's talk about what are your values for living well. And if you're scared to have it, let's explore a little bit about maybe the fear of having the surgery. Or if you've already explored that and you just really don't want the surgery, then let's talk about like accommodations that we're going to make because you're not going to be able to drive again anymore. But really, you've got to give the power back to the person who has who's living with whatever it is. Like,
Right.
yes, cataract surgery, but that's a big medical decision because that will affect quality of life. But if the doctor thinks that it's too high risk, let's talk about the risks and benefits of having it and explore the reasons for why you don't want to do it.
That's it's such a good point because I think sometimes, or I'll say I'm guilty of it, I don't ask those probing
Mhm.
questions as much.
Yeah.
Certain things just seem obvious to me, like you have cataracts, you need cataract surgery. Okay, like it's a simple discussion. But I
Hmm.
appreciate what you're saying, which is there is a perspective and baggage and history and fears and anxieties that a parent or an older adult might have that
Hmm.
maybe that's not what they're saying, but that's what's
Right.
underlying their reluctance to do something. And so finding the ways to ask that
Yeah.
is where it's important. And I love to what you're saying about the humor about having somebody sort of tease your dad about walking down the stairs backward and also finding that family member who can have those conversations. I mean,
Hmm.
you come from a little bit bigger family than I do, but um, I know what you're saying. Like sometimes somebody in the family can have a conversation in a way that maybe somebody else can't.
Hmm.
And I mean, is your family intentional about saying like, okay, you ask mom or dad that, or I'll tackle this because I have a dialogue with them. Like, how
Yeah.
do you navigate that intentionally?
I mean, I think somewhat. I mean, I think in our situation, um, my mom has kind of identified me as the person that she feels most comfortable talking with about some of these things, even though my sister is a doctor.
Hmm.
But like, and to ask your parent, like, who do you want to talk with both of us about this? Or do you want to, is it just one person that you want to talk about? But let's just kind of figure this out and just let them kind of identify who they want to talk with about the decision. I mean, for example, my mom, we were thinking she would never use oxygen. And then I just asked her, I was like, hey, would you ever use oxygen if it gave you better quality of life so you could still go for walks? And she said, yeah, of course. And we were
Hmm.
all shocked that she said that. So we really thought she would never have said that. But so you don't know until you ask. And the person who it seems, I mean, not everybody, of course, but it seems like the person living with the illness does want to be asked. They do want, to have these conversations because there's so much that people are holding inside about these things. Like who can you talk to about your fear of this or that, maybe you like for a cancer patient, maybe you really don't want chemotherapy or immunotherapy, any kind of cancer directed treatment, but you feel badly saying that to your family. So, but if you can sit down and tell them this is out of love and a gift to us and a gift to you, if we can really have these conversations, then I think people do start opening up because they haven't always been given these opportunities. Like it's fairly new that people really can sit down and have the space and time to talk about these things.
Something that resonated with me about what you said before was you went to visit your family because your dad is going down the stairs backwards. And so that was kind of a primary reason for your visit. But of course, then you're enjoying your time with them and like you don't want to face the elephant in the room, or at least that happens for me sometimes. Like I know I have to have this conversation. And
Mhm.
so kind of finding a good way in or finding a time when maybe you're like alone with your parent and nobody else is
Mhm.
around or in my dad's case, he could probably really benefit from a walker. He does not want anything to do with a walker. We try to get him a wheelchair at the airport and he tells the wheelchair guy to go away, even though my mom is with him, who's in a wheelchair. So my younger daughter kind of we were walking around town and he's kind of wobbly on his feet, and she can look at him and say, "Oh my gosh, you need a walker. Why are you not using a walker? Like you're making me nervous." And she can say it in a sort of joking way that she can open up the dialogue with him a little bit and they
Mhm.
can have a conversation and sort of like kind of laugh about it, but it brings it out into the open. And so now it's like another one of us can say, "Hey, like let's talk about this, right? Why don't you want this?"
Hmm.
And to your point, giving them back that power to say why they do or do not want the thing.
Yeah.
Because a lot of time, maybe they do, maybe they
Hmm.
are open to it, but you've just assumed that they're not,
Right.
which I think kind of happens probably a lot.
Yeah.
So, what about the parent who doesn't think they need any help or intervention, but you think that they do? Like, how is a polite and respectful way into that conversation?
Hmm. Well, I think the same thing of letting them know, like, we're asking these things because we love you. And
Hmm.
so, um, if they don't want to have the conversation, you can say, you could start with, and like you said, identify the person, the setting, whether it's outside the house. Like some people like to have these conversations when they're sitting outside or going for a walk or in the car, like kind of figuring out the best venue for it. But again, asking them, like telling them this is for you so that we are respecting your decisions, that we know what you want. All we're doing is making sure we know what you want and what you don't want. And so if we can really have a conversation about this, once we do it, we can revisit it again in 6 months. We don't have to keep dwelling on it. But we would really like to get a sense of where you're at right now. It is difficult. Like that's what I'm saying. Like when we went back home, like we thought we could just have this conversation, but it just never felt like good timing.
Hmm.
And a lot of people will push back because they're defensive or get angry. And you're like, hey, listen, we just want to do this because we love you. And we're going to
Right.
be your medical decision makers. And we really want to make sure we get it right. And so when you put it back on, this is for you, we're doing this out of love. Let's have the conversation. And then we don't have to have it again
Right.
for a while.
Right. We don't have to you can let it go, right? You can say your piece and then you can move on and maybe you're going to have to circle back. And I think also something that I've learned is if you have a good interaction one time, like for instance, my mom finally let us sit in on the calls with her doctor, her primary
Mhm.
care physician. And I can't remember, something happened. Maybe I think it was during COVID and I was there. So there was a video visit. And so we took advantage of that and I joined in and I, was quiet and listened and tried to be really respectful and ask questions at
Mhm.
the end. So it was a good experience. And so then they're sort of more willing to let you participate. And I remember my mom had to go to the emergency room because she was having digestive issues, which turned out that she needed to have her gallbladder removed. And we were driving home from a concert and we were in the car and the phone rings and it's my mom on speakerphone with the doctor there. And I was really glad that she called me. Of course, I had a car full of people, so it was like, okay, everybody be quiet. I'm talking to the doctor and at the hospital. And we're going through the interview. And so he says to my mom, well, do you have any underlying health conditions before we go into surgery? And she's like, oh no, I'm fine. I'm in great health, right? And it's like, oh my God, mom. I mean, that's just not true. I mean, you're on many medications, you take oxygen, there's other things happening. And I think in that moment, like when you're in the ER, it's the hospital, you're anxious, you're nervous, like we all forget, right? We forget what to say. But I was
Mhm.
really glad that she trusted me enough to call me, to have me on the phone so that actually I could deliver meaningful information to the ER doctor about
Mhm.
all the things. Because I think they forget. And so for me, it's been nice that on my mom's side, she's finally welcomed it and appreciated the assistance. Um, my dad a little bit, not so much.
And it sounds great that that first time that you were on the phone with your mom and the doctor when things weren't a crisis, but you were just listening in on the appointment, they can start thinking, oh, okay, she's not going to just step in and keep interrupting what the doctor says, or she's not going to speak for me. Like just setting that stage, I think is really important the way you did that. And then, like you said, then it carried over into a time where she needed you and she knew, oh, wait, that you were great that time. Let's call
Right.
and see how it goes. I mean, I think that is really important to do that. The spouses are going to feel differently about things too. Like maybe somebody's like, I love to talk about this and let's get this down and write it down and write down a living will and maybe do a do not resuscitate. And somebody else is like, no, I don't want to talk about any of that. It'll make it happen. I'm fearful. We'll just see how it goes. And that just doesn't usually go very well. Like these conversations that we're talking about, like the palliative care conversations, are much better when it's not in crisis,
Right.
when it is a calm time to really be thoughtful about people's medical goals for care. Like we start all conversations with like, what are your values for living well? Like what really is most important to you? What brings you good quality of life day to day? And really include those in your day to day living. And then when those start decreasing, then what are your medical goals for care? And how can we always make sure your values are part of your life as much as they can be? But certain things like travel or going to concerts like that, those may change over time because,
Hmm.
people's worlds get a lot smaller when they have more challenges from a life limiting diagnosis or coming towards end of life too.
I mean, I love that entry of what are your values for living well.
Yeah.
That's something that we should all be thinking about all the time,
Yes.
right?
Yes,
As we
for
make a
sure.
lot of decisions, but I think it's just a nice way that doesn't feel healthcare driven.
That's where palliative care comes in. I mean, that's really where, like, some people will think palliative care is a luxury, but at the same time, it is not a luxury. It should be part of an integrative health system. It is looking at the whole person. It's a holistic approach to care. I mean, our conversations start with, what is your understanding of your medical condition? Because we
Hmm.
can look in somebody's chart and read all of it, but when you ask somebody, you may get a totally different answer. They may not have a full understanding of their medical condition. And we ask, like, do you want to talk about this will look like as it progresses? Like what some of the challenges what challenges will come up for you? And then we move into what is acceptable? What are your values? And then we move on to what does a good day look like? And knowing that people will change their mind about that over time. And then what are you hoping for your outcome for all of this? Like how can we help bridge sort of the your hopes and wishes for care to what treatments and resources are available? So it's really not a luxury. It should be part
Hmm.
of all conversations, and it can be very upstream, like you said, like a cataract surgery. It can be when somebody's diagnosed with heart failure or renal disease, but it hasn't totally affected them. And then it can be again when the challenges increase and the care needs increase, and then it can be end of life care. So there are so many stages of palliative care that are really so essential to making sure people get good health care.
It's interesting because I think I at one point mentioned to my mom something about why don't you get connected with a palliative care person? Maybe that would be really helpful for you because she has some stuff she's dealing with. It's not completely impacting her life, but she was
Mhm.
very clearly like, oh, no, 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 I don't need that. Like, that's for the very end. And so
Yeah.
I feel like you're right. Obviously, that perception of palliative care being confused with hospice care
Mhm.
is probably like a huge opportunity to share with people. There is this kind of midterm, it's almost like a coach kind of, right?
Mhm.
Like we're going to ask you what your
Yeah.
goals and aspirations are for this phase of life, and we're going to help you achieve that.
Yeah, and it's really to help ease suffering because when people fight against some of these things, suffering just goes up. And so when people have a chance to talk about this and help with coping and adjusting, like it's a big deal if you're like a big marathon runner and then you start maybe running a little bit less. And then one day, for whatever your health, diagnosis is, you can't run anymore. So we talk a lot about adjusting to these changes in life. And so it is really important for people. I mean, I think for a lot of people who are interested, it's so valuable to have these conversations. I mean, we'll meet with people who will say, "Gosh, why didn't I meet with you like 5 years ago?" And it's like, well, because we didn't get a referral. Like, but when there's more education around palliative care, people can self-refer. They can find organizations in the community. Like, there's so many people who offer this service. Um, And it can be once. You can have this one-time
Mhm.
conversation and then maybe connect with the team again in 2 years. At least it's kind of setting, it's like planting the seed, like kind of setting the stage for what's to come.
Right. And maybe you have a relationship with that person, so they
Mhm.
have some history on you, they know where you were, they know what was important to you sometime in the past, and they can
Yeah.
kind of help you as you move through different phases. What are people most afraid to say or talk about? And something that you said a few minutes ago kind of reminded me of this. It's the notion that if I talk about it, it will happen.
Hmm.
So, can you just talk a little bit about, how do you help people navigate their way through the things that they least want to talk about? I mean, I guess death,
Yeah.
right? Obviously, nobody wants to really talk about that. But like, what are those things that are really like the last bridge nobody wants to talk about, and how can we maybe do better opening those
Yeah.
doors?
I mean, I think that's where the rapport building really comes in, where you start meeting with people earlier on, so they start feeling more comfortable about talking about the things they least want to talk about. But I think for everybody, it's a little bit different. I mean, I do think a lot of people some people, I think more people fear what the suffering would entail prior to dying than the actual being dead
Hmm.
part. And so when people talk about that, people will start saying, okay, I want to know what to expect. And then we'll start talking about it. And people are like, no, I'm not ready for that. And so it's really when somebody's ready for it. Even the things that people least want to talk about, at some point, they do want to, more open to it. And maybe it's when they are coming closer to the end of life and really talking about how will my family be supported while I'm dying and after I'm dying. That's a big one. I think a lot of people worry so much about their family, even more than themselves. Like, what is it going to be like for them to care for me in my last weeks, days?
Yeah, I think it's so interesting because as a mom, right, I'm always thinking about that, right? Even if I'm in the hospital, I'm sick, something's wrong with me, it's like, well, how can I make sure my kids get where they need to go or they're going to get fed?
Hmm.
And I guess in my mind, I hadn't thought about that coming into play at the end of your life.
Yeah.
But of course it does, because I mean, even though you're the person getting ready to go to the next phase, you're
Hmm.
worried about the people that you love and you're
Yeah.
leaving behind.
Yeah.
Yeah.
And people don't want their family to see them suffer or to see them in such a, I don't know, I don't want to say incapacitated, but in such a way that they need help with everything. People don't love talking about that. But then there's always people who do. I mean, then people are like, no, I want to know everything. Tell me
Uh-huh.
everything about what it's going to look like. And that's where the family then is like, hold on, I don't want to hear everything. I mean, it is so interesting, like being in these consults, like you have to be able to sit in the uncomfortableness of the consult because people really come at these things so differently, even whether they're married or they're a child of the, person experiencing the illness. But that's kind of a big one, is what
It's hard
people
to
don't
have
really
that.
want to talk about.
Yeah, and it's hard to have that discomfort with your own family.
Yeah.
So, I mean, having that neutral party, that palliative care specialist or therapist or whatever, right? It's hard to sit in that discomfort
Mhm.
anyway, and especially with an aging parent, I think.
Yeah.
And then you want to fill the silence, right? So, but that
Yeah.
practice of just asking and listening.
And really respecting the silence. Like there's a lot of silence in some of the heavier consults where you just sit with the silence until, giving people the time to process all that they're thinking about and wanting to share or not share with their family.
This may or may not be a topic that is your specific area of expertise, but I just wanted to put it out there because I know during the pandemic, for instance, we started to have some conversations with my parents about let's make sure we have the right documentation, right? Like in
Mhm.
case something happens and you do end up in the hospital. And so, I went on the web and I researched what do I need. And I think it was like a medical power of attorney and an advanced care directive. I mean, are there documents or things that you recommend for families to put into place as a part of your role? And if so, what are those?
So the biggest one is the medical durable power of attorney form. And especially in Colorado, because in Colorado, it doesn't legally fall to next of kin to make medical decisions. Is my understanding is Colorado is one of two states where that is the case. So if you don't have a medical power of attorney form, then and you are no longer able to make your own decisions, whether you're just super sick or you have dementia, um, then they have to do a proxy in the hospital. And a proxy means you have to call all interested parties. So everybody in the family has to be called, and they have to all have consent on who the point person is going to be. So really everybody 18 and over should pick a medical power of attorney. And you pick the primary person, and then usually there's a spot for two alternates. You can have more alternates. And the idea is that families will make these decisions together behind the scenes, but the doctors need a point person to call to make all these medical decisions. And so to me, that's the most important one to do, that form. And that's why the medical power of attorney, it's so important for people to share with their family what their wishes are, because the medical power of attorney is going to come into play when there is a crisis, when the person is not able to say what they want. So really, for me, if I'm going to pick somebody to be my medical power of attorney, I have to pick somebody who I know is going to respect my decisions,
Mm-hmm.
even if they're not what they want for me or what they want for themselves. They really have to be able to speak in my voice. And the thing about the medical power of attorney is that they have full right to make all the decisions. So for example, the other form that we talk about a lot and complete a lot is in Colorado, it's called a MOST form, a medical order for scope of treatment. Every state has their own. In some states, it's called a POLST. In Colorado, it's medical order scope of treatment. And we fill that out if somebody does not want an attempt at resuscitation. And then underneath that, there's a spot for what level of care do you want in the hospital? Are you okay with intensive care unit, breathing machine, ventilator, like everything the ICU has to offer? The second part is selective treatment. I'm okay going to the hospital for something that's, somewhat fixable, like an infection, like pneumonia, going there, getting IV antibiotics. I don't want to escalate my care to the ICU. I want to go home and recover. Or comfort, which means I don't want to go to the hospital anymore. So that's another form that's really important to do. But the medical power of attorney can overturn even that form. You hope they don't. You hope you pick somebody who will respect everything that you want, but they really do have the ultimate decision, ultimate decision making for the person who can no longer make their decisions.
I've never heard of this most form.
Yeah, so the most form is great. I mean, that's another thing. I mean, it takes a long time to go through it. I mean, I just kind of just told you really fast,
Right.
but that's another form where you really say, what are your values?
Mm-hmm.
If you have resuscitation with your type of illness, what will the outcome be? Will you be in a worse situation than you are now? Or if you have cancer and you get resuscitated and you're dying of the cancer already, like there's just
Right.
so, I mean, it's this huge conversation. And it's really for people who are clear they do not want resuscitation. And that's another thing some people feel very strongly and they know for sure they do not want resuscitation. Other people say, I'm just going to leave it to my medical power of attorney to decide. The other thing is somebody could have a do not resuscitate, and let's say they are at home and essentially they've died in front of you,
Mm-hmm.
and they have a do not resuscitate order on the fridge or the back of the front door, but you start freaking, you're just like, oh my gosh, I can't do this. I have to call 911. And that's the medical, then 911 comes out and they can help determine what to do. But, it's still doesn't always make, it's not foolproof, I guess.
So that brings up a secondary question is like, where should you have these documents? I
Yeah.
mean, like I did it with my parents and I think I saved them to my cloud. But could one of my other parents in a moment of distress, like get on their phone and find a document in the cloud?
No.
No, probably not, right? So, I
Yeah.
mean, it's like I mean, and you just alluded to on the refrigerator, which I don't feel like I want that living on my
Yeah.
refrigerator, but maybe at some point I will. But yeah, like, is there advice? How do you make this information accessible?
I mean, I think with that most form, it's bright green. It's a fluorescent green. It they do recommend it goes on the refrigerator, the back of the front door, so paramedics
Oh,
can see it. And that's usually going to be put up by somebody who's kind of, having a lot of challenges related to their illness. The other
okay.
thing you can do is you could put it in an envelope and put MOST on it. Um, but a lot of people just stick it in their junk drawer and we're like, oh, it looks like you have a DNR. And they're like, oh, yeah, I filled it out. I don't know where it is anymore. And so that's not going to help anybody because paramedics aren't going to come to somebody's house and look through their medical record. If they don't see that form, they're going to do
Right.
resuscitation. That's the default. So,
So we created a healthcare binder for my mom.
mhm,
At one point, she was having a lot of issues, and so my daughter and I created this binder, and it has like we keep all her notes from her visits and her medications and things like that. And I guess, I mean, that would be a place you could put something like that in.
mhm.
But then I do love that when she comes home from a doctor's appointment, I'll say like, "Oh, did you bring your binder?" And
Yeah,
like, no, I mean, she's not bringing that binder with her. But um,
yeah.
or she went for surgery. Like, I guess it's incumbent upon us to make sure it's there, but at least I guess we know where it is. And actually, even in my parents, now I'm like a guest on their electronic health records. And so you can upload it into the EHR for them. So I don't know if like that's a place where healthcare providers look, but presumably,
I mean, yeah, all of that is in the medical record if somebody has
yeah.
completed it. The medical power of attorney that is there, the most is there, as long as they have sent it in and given it um, to their primary care doctor or whoever, it's on the health record. But um, but the DNR has to be seen by paramedics in order for them to follow it. It has to be signed by a doctor. And so that's something else. Some people are like, oh, yeah, I filled it out myself, but it has no doctor's signature. So then it's not a real order. Paramedics won't follow it. It has to have a doctor's signature on it. Yeah.
So thinking about your experience and all your knowledge and expertise, how have you put what you know as a professional into play with your own parents? Like, are there things that, you've been able to implement that you would recommend for others?
I don't know if I use my parents even as an example. I mean, because in my family, like my mom is very open about having these conversations and my dad is not. So I think for us, the way we have done it is just little by little. And I think that's really the only way to do it, unless you have a family that just really wants to sit down and have a full conversation about these things. It seems like kind of introducing the idea a little bit at a time. That's what's worked best in our family.
I think that's right because you get overloaded, right? These are
Yeah.
emotional, heavy topics. I mean,
Hmm.
recently I was home and I had a very emotional, tough conversation with my dad about some of these things, but it was kind of a watershed moment where it opened the door for future conversation. We just sort of acknowledged like the reality of where we are. And I think that feels right. Just sort of, okay, we're going to sit with this. We're
Hmm.
going to accept some of these things we've just talked about and then break it into small chunks, right? And in the future, break down some little pieces and parts
Yeah.
because it's too overwhelming
Hmm.
to broach all these topics at once. And
Yeah.
it's like, it's depressing. I mean, people don't want to face the reality up to a certain
Yeah.
point
Yeah.
where you need to. So,
And I think the thing to remember is there's no real right or wrong way. You're just doing the best you can. Like all of this is just doing the best you can. And um but yeah, and you also don't want it to be like every time you see your parents are like, oh my God, now that all she wants to do is talk about like all these medical decisions. And it's just like, no, I don't, like you also don't want that to be a relationship. So that's another thing we talk about a lot is you want to be their daughter you don't want to be the caregiver all the time. Now,
Right.
once in a while, you will have to be, but you don't want it to be like that all the time. You don't want them every time they see you, they're like, oh, like we're going to have to talk about this again. So
Yeah,
it's,
for my mom, it's the decluttering. She's like, "Oh, I know you're going to go there. I know you're going
yeah,
to want to throw stuff out. It's the
yeah,
Swedish death cleaner has arrived. What is it
yeah.
today?" And
And so
so,
you
yeah,
surprise them,
I
show up, and you don't even
know.
talk about the clutter. Just like, surprise, guess what? We didn't talk about the whole trip.
I know. I work hard to keep it off the table. And even then she'll think we talked about, in her
Yeah,
mind, she'll just be convinced that of course we had 10 conversations about it, even though I
right.
consciously was like, I'm not bringing one thing up. And
Yeah,
it's not easy. It takes a lot of self-restraint at moments. So,
yeah. And I think that that's also, the way we talk about like asking people who are living with a life-limiting illness, like, what do you want your values to be? What do you want your relationships with the people in your life to be like? Those are the same for all of us. Like, what do you want your relationship with your parents to be like? And what's most important for the time that you do have together, knowing that who knows, anything can happen at any time. And so, how to make those moments as good as they can be within reason. Like, we don't live in like this idealistic world that everything's perfect, of course, but make, at least part of the visits as nice as they can be for everybody. So,
I
and
agree.
the one thing we didn't talk about that we don't have, have time, but like is dementia. And so I was just going to add, like, for people who have memory loss, there is an advanced directive for people with dementia that people can get online, because that's a really good um, conversation starter, especially from the time somebody is diagnosed with dementia, to have these conversations, because the medical decision making will fall very quickly to the medical powers of attorney um, to decide what to do for somebody who has memory loss. And that's where the values, how did mom or dad live their life? What was most important to them? What did we talk about in the past where they said, no way, I don't want to live that way? And really taking into account all the, how they lived, what they said, and what their values were will be really important for decision makers when somebody just can't make any decisions.
It's such a robust topic, right? Because also
Yeah.
there's phases along the way where, maybe there's some cognitive decline
Hmm.
and maybe you see it, but maybe your parent might not even be aware that it's happening, right? And
Hmm.
so, um, trying to be mindful of that, and then it might get worse. And then do they change? I mean, kind of like what you were saying earlier, sometimes people change their mind based on a
Hmm.
diagnosis or where they are. So, that might be changing their mental acuity and their cognitive function might be declining. And so,
Hmm.
thinking about all this in light of that, that's a lot.
Yeah.
Yeah.
Yeah, that's a whole nother
That might be a whole
conversation.
nother episode.
Yeah. I mean,
But I
but it
think
is a
it's
big part
important.
of the
Yeah.
people we see in palliative care now. Like, it's a huge number of patients that in palliative care that have memory loss.
So you do that comes up and you do bring it up.
Yeah, it comes up
Yeah.
daily, every day.
Well,
Every day.
is there anything else that you wanted to share about palliative care or experiences that you wanted to share before we wrap up?
No, I mean, I think the biggest thing is like it would be great if um I think just more education around that it's very different than hospice. And even though it's been, I think 15 plus years that it's become a specialty, like, still people are so scared of having these conversations that it helps outcomes and it helps people's quality of life, even just to be able to talk about some of these things. And I just think they're such valuable, such interesting. Some of them are such philosophical conversations that it can sometimes even bring families together. So I'm a huge proponent.
Well, I'm so thankful for your expertise and bringing it to us today and sharing it with us because I do think it is an underappreciated area and there's a lot we can all learn so we can do better as we navigate this phase of life. So thanks for your time. I really appreciate it. And maybe we'll have to do a follow-on episode to talk about some of the
Yes.
things we couldn't get into today.
Yeah. Well, thanks for having me. It's great talking to you.
Thanks. Bye.
Bye.
Gets the China is written and hosted by Kirsten Mao, produced by Aaron Bryce of Blue Ogden Productions. Our theme music is composed by Greg Fellman of Wind Sand Productions. Our cover art is by Jen Beam of Gigawatt Studio. For more stories and expert advice, follow along on Substack or at www.whogetsthechina.com. If you enjoyed this episode, please share it with someone who might appreciate the conversation. And don't forget to rate, review, and subscribe wherever you get your podcasts. Until next time.